Good morning. I just wanted to go ahead and record this for you all. The Test for Meds extra resource. Originally, I was not going to record it. It was just going to be an extra resource for you in class. But someone had asked me about it, and I decided to go ahead and record it for you. That way, you'll have it, and it'll be something extra you can study. So, like I said, it's not an all-inclusive list, but it is a good resource for you regarding the lecture. And like I said before, a lot of times when I'm doing the lecture, I don't feel like I concentrate enough on the meds, so this is why I went back and created this. So, Kayexalate, this is, of course, a review. We did talk about this medicine. It is given for increased potassium, and it actually removes the potassium. So it's not a temporary fix, but it will remove it. It can be given PO or by enema if the gut's not working, or if there's a paralytic ileus, you definitely wouldn't want to give it PO. So you can give it by enema. Other meds are the regular insulin IV, and you have to give the glucose with that, because as the potassium, when you give the insulin, potassium moves into the cells, and when you give the glucose, that just kind of counteracts or prevents hypoglycemia. So that's kind of the thoughts there. And then you can do sodium bicarb, and it just kind of corrects acidosis because it causes a shift of potassium into the cells as well. And then your calcium gluconate, that's more or less for to help the heart, right? To prevent and help the excitability of the heart. Usually that's given with evidence of hyperkalemic ECG changes. But it helps also, it helps prevent those dysrhythmias, which can be lethal. So those are just some of the things. And then we talked about in class, of course, hemodialysis, which is not a drug, but it will remove the potassium as well. The other meds, insulin, glucose, sodium bicarb, calcium gluconate, sometimes those are just a temporary fix, or it may be something they try before they put them on dialysis, because they're not just going to wheel them to dialysis immediately. So they, especially in acute kidney injury, they are going to try to reverse it, and dialysis is often last resort. And same thing with chronic. You have to wait, till the GFR is less than 15 or less for chronic, for a chronic patient to be started on dialysis. So just keep that in mind. So phosphate binders, you got your calcium carbonate, your calcium acetate. Everybody remembers when they phosphate binders. You take them with meals, and they can cause constipation. Most patients that are on dialysis, they need the phosphate binders. It does say in your book that it's individualized, and I think it says 0.6 to 1.2. Yes, page 1114 in the 9th edition, table 4710. And it is just your nutritional therapy. It does, it talks about pre-end-stage kidney disease, hemodialysis, and peritoneal dialysis, and it breaks it all down for you. I would be familiar with this chart. The phosphorus is for hemo and for peritoneal. It says individualized 0.6 to 1.2 grams a day. So most likely, 1,000 milligrams would be a good dose, but usually they take with meals and it binds with the phosphorus in the gut so that it can be excreted. And just like I was talking about, it must be combined in combo with a controlled diet, and you do not take it with iron. Any type of calcium can decrease the effectiveness of iron. And then if the patient already has some elevated calcium levels, then they're going to use something that is not calcium based, right? So that would be your lanthanum carbonate or your sevelamer carbonate. Those two could be possibly used as well. Alright, and let's talk about EPO or Epigen, Procrit, has so many names. Darbepoetin. Remember, this stimulates the bone marrow to produce red blood cells. You only want to give it if the patient's anemic, usually 8 or less. A lot of times they'll monitor this closely, and your book does talk about that if it's greater than 12, you would not give it because there's an increased incident of heart attack, throwing a clot, thrombosis. So you would not give it if it's greater than 12. So they monitor this pretty closely when it's being given. So keep that in mind. It's usually given sometimes when you give EPO, you'll give iron if the ferritin is less than 100. Always give iron. And like I said, it doesn't have to be given immediately with it, but it is often given in conjunction. It can be given IV or sub-Q, and the side effect is hypertension, headache, nausea. So those are some things about it. And then, of course, the iron can cause some GI upset. And again, don't give your iron with your phosphorus or calcium products. Lactulose is given to decrease ammonia, and normal ammonia levels 15 to 45. It traps the action of the lactulose. It traps the ammonia in the gut, and it excretes it in the stool. So remember, ammonia is a byproduct of protein metabolism, right? So your nitrogen binds with your hydrogen, forming ammonia. And it's very toxic to our cells. That's why it's so important for the liver to get rid of it. Ammonia is converted to urea and by the liver. So the liver has to be working to convert that to urea. And it passes through the blood, and it's excreted by the kidneys. So just keep that in mind, that it is, a byproduct. It's waste, and it's very toxic. So that is why we want it. That's why you're going to see these changes. We talk about the hepatic encephalopathy that it causes as it builds up. So that's why the lactulose is so important to give if the patient is experiencing any of this. Aldactone or spironolactone is basically an aldosterone antagonist. It blocks the action of aldosterone. Aldosterone's not, a lot of times because of the damage in the liver, aldosterone cannot be metabolized, and you'll get hyperaldosteronism or increased aldosterone, which causes an increase in sodium reabsorption. Then that's when you get your edema, your increased blood pressure, So that's why the aldactone is often given. And if you see over here the little balloon, it is potassium sparing. So save the potassium, get rid of the water. That's what he's saying. So that is, and then we also talked about, remember, when someone has the increased aldosterone or hyperaldosteronism, the intravascular volumes decrease, right? Because it's pulling the fluid out of the pipes, and subsequently renal blood flow and glomerular filtrations decrease. So you're going to see some signs of dehydration, dry tongue, skin, sunken eyeballs, and then you may even see some decrease in urinary output. So keep that in mind as well. And that, we were talking about ascites and how sometimes the patient might have sunken eyes, and just, a really round belly. So, that's the hyperaldosteronism. And often they'll try the aldactone. Some other meds for liver failure. Like I said, they'll also try some other diuretics. They'll try loop diuretics. Again, with loop diuretics, you have to watch the fluid and electrolytes very closely. And these other potassium-sparing diuretics, amiloride or triamterene, those are often tried. And then also you've got to think about, okay, you've got all this extra fluid in the gut. The ammonia can cause inflammation, and you've got the gut bacteria anyway. Well, the ammonia can cause all of that to get out of balance, and you can have an overgrowth of bacteria. So that is why you often will give when there's a buildup of ammonia in the blood, in the gut. Rifaximin and neomycin are often given. They decrease bacteria in the gut and therefore help decrease the ammonia formation. And then treatment of bleeding varices, we talked about that. Vasopressin, often given with nitro, and then your octreotide or your sandostatin. Remember what I said about sandostatin or octreotide? It's specific to reducing portal venous pressure. It's a somastatic agent. It decreases blood levels of a variety of hormones. There's a chart in your book, 4413, and that's in the 9th edition, page 1024, and in the 10th edition, table 4314. Those are the drugs. Those are some drugs that I would be familiar with that table. It's a good table. We talked about most all those drugs, but it just kind of helps you see it, in the table form and in the book. No, let's don't forget about PPIs, just because they decrease the gastric acidity as well. And then your long-term for varices, that's on the chart as well. It talks about some beta blockers, propranolol, and that just reduces the portal venous pressure, therefore reducing varices. Like I said, that would be more long-term. And then you got your transplant meds. Again, there is a chart in your book for that. That is page 222 in the 9th edition, table 1416. And in the 10th edition, I'm not sure the page number, but I know it's table 1316. And talks about the different meds. And they had asked yesterday in the out-of-class support what meds they needed to know. And we said concentrate on the first half of that table. So your corticosteroids, your calcineurin inhibitors, and your cytotoxic or anti-proliferative drugs, which is right here in this table. So remember, your calcineurin inhibitors or your immunosuppressants. That's your cyclosporin. Side effects: increased risk of lymphoma, leukopenia, decreased white blood cells. Remember, don't take grapefruit juice with it or St. John's wort. And then your anti-proliferative drugs or your immunosuppressants. That would be your Imuran. It's not listed here, but I added it. So your Imuran, Cellcept. Those side effects are your bone marrow suppression, your increased risk of infection, anemia, thrombocytopenia, and increased risk of malignancies. So keep that in mind as well. And then your corticosteroids, your Ciumedrol, your prednisone. The side effects of those: peptic ulcers, hyperglycemia, hypertension, increased risk of infection, sodium and water retention, osteoporosis. Remember, we talked about the bone, the joint necrosis, and how a lot of times they'll have sore joints. We'll have to check their blood sugars. We talked about all that in class, so remember that stuff. And that is it. And it's a short video, 16 minutes long, but I did want to go ahead and give you this just, like I said, as an extra resource for you. And hopefully, I feel like I'm getting somewhat of a cold, or I've been fighting a cold off. So hopefully it's loud enough, and hopefully it'll be of good use to you. And I hope you get a lot of studying in, and good luck with the test.